بسم الله الرحمن الرحيم. Core pulmonale. Definition. Core pulmonale is the traditional term for changes in the cardiovascular system resulting from the chronic hypoxia and usually hypercapnia of chronic lung disease leading to pulmonary hypertension. And pulmonary hypertension is precapillary due to raised pulmonary vascular resistance and is usually mild, moderate, and does not tend to progress. And a subgroup of patients may develop severe pulmonary hypertension disproportionate to their lung disease, and core pulmonale presents with peripheral edema. Core pulmonale can occur in the most situations where there is chronic hypoxia, and most often in the setting of hypoxic and hypercapnic chronic obstructive pulmonary disease, and occurs in hypoventilation syndromes due to scoliosis, neuromuscular disease, or obesity, and much less common when there is no associated rise in PaCO2, such as with interstitial lung disease and high altitude at the right to left shunts. Core pulmonale is often also referred to as a right heart failure, which is misleading as the cardiac output in core pulmonale is usually normal or high with increased peripheral perfusion, hence the bounding pulse and warms preference of the type 2 ventilatory failure. If allowed time to adapt, the right ventricle can generate much higher pressures, such as in idiopathic pulmonary arterial hypertension, that are usually seen in core pulmonale and responsive to hypoxia. In true right heart failure, the right ventricle fails to develop adequate cardiac output following right-sided myocardial infarction, MI, or pulmonary emboli that include a large proportion of the pulmonary vasculature bed that as this rarely occurs in core pulmonale. This also produces a raised jugular venous pressure and occur in the fluid overload of core pulmonale, but in contrast, there will, of course, be a low cardiac output and poor peripheral perfusion. Again, core pulmonale results from the following sequences of events. Lung disease causes hypoxia, cyanosis, and sometimes polycythemia. Hypoxia acutely causes pulmonary vasoconstriction and chronically causes pulmonary vascular remodeling, and this leads to pulmonary hypertension. In addition, hypoxia is sensed both within the kidney and via the carotid body, generating increase in symptomatic sympathetic activity and renal vasoconstriction. Again, last sentence. In addition, hypoxia is sensed both within the kidney and via carotid body, generating increases in sympathetic activity and renal vasoconstriction. Increased sympathetic activity and other mechanisms leads to renal retention of salt and water. This extra salt and water are mainly held in the capacitance vessels, the large veins, often with a raised jugular venous pressure. If vascular permeability rises, particularly when PaCO2 rises, producing peripheral vasodilatation, and an increase in the capillary pressure, extra fluid accumulates in dependent tissues. Patients of corporal pulmonale often present with their first episode of ankle swelling during an exacerbation of their COPD when for the first time the PC2, PCO2 rises and the PO2 falls far enough to provoke above events. Body weight may not acutely rise very much with the onset of the ankle edema. However, the extra salt and water retained in the capacitance vessels leading up to the exacerbation moves into the subcutaneous tissues properly due to the CO2 induced vasodilation, rising raising mean capillary hydrostatic pressures. Loss of pulmonary vascular bed from emphysema also contributes to the raised pulmonary artery pressure, and the ACG often shows right ventricle hypertrophy, although this is not sensitive. Echocardiogram is the best non-invasive test, but it is often not possible to obtain good images due to hyperinflation of COPD or obesity, and the right heart cath is the gold standard test, but is rarely necessarily but is rarely necessary unless estimated PAB is disproportionately high on echo more than 4 40 millimeter mercury. During an exacerbation, extra hypoxia will produce further rise in PAP, with which the hypertrophied right ventricle usually copies, helped by raised jugular venous pressure, providing a larger preload to increase right ventricle filling. Excessive diuretics can lead to a true fall in the right side output due to inadequate filling of the right ventricle. The clinical features of the cor pulmonale and investigations include the following: features of the underlying disease causing the hypoxia, let's say, as for example, chronic obstructive pulmonary disease, bronchiectasis, easily vegetable veins, and a raised jugular venous pressure may present, cyanosis, and asuphist conjunctiva, polycythemia, and vessel dilatation from the raised CO2, and sometimes marked polycythemia, very rare, a consequence due to hyperviscosity, peripheral vasodilatation with abounding pulse and warm preference, ankle edema, ankle swelling and pitting edema, right ventricle hypertrophy, sternal heave uncommon, masked by hyperinflated lung between heart and chest wall, and more often seen with the higher pressures of idiopathic pulmonary arterial hypertension, tricuspid incompetence, not usually severe, chest X-ray, enlarged pulmonary arteries underlying lung disease, full blood count may have associated polycythemia. Oximetry core pulmonale is unlikely if awake SaO2 more than 92%. Blood gases core pulmonale progressively more likely as VO2 drops below 8 kPa, equivalent to SaO2 equal to 91%, and PaCO2 rise above 6 kPa. ECG may indicate right axis deviation, P pulmonale, right atrial hypertrophy, and right bundle branch block, echo dilated or hypertrophied right ventricle, tricuspid regurgitation, providing estimate of PAB and exclude other diagnoses such as patent atrial septal defect, overnight oximetry to reveal unexpected degrees of hypoxia, from the obstructive sleep apnea, OSA, or obesity, or neuromuscular disease, and consider referral for right heart cath where pulmonary hypertension disproportionate. It's to say more than 40 millimeter, more than the pulmonary arterial pressure is more than 40 millimeter mercury. The management of core pulmonale. Core pulmonale is a marker of poor prognosis in COPD with a 5-year survival rate of about 50%. It's not clear if this relates to pulmonary hypertension or severity of COPD. Long-term oxygen therapy is the main treatment in patients with core pulmonale and hypoxia when PaO2 below 8 kPa and improves survival. Minimal ankle edema needs no treatment. Timing, Trimming the ankles to normal is unnecessary and may reduce right ventricle output by reducing right ventricle filling. If edema is more substantial, then the following may help. Treat the underlying condition to raise PO2 and lower PaCO2. Raise PaO2 through added oxygen. Provide long-term oxygen at home. In hypoventilation syndrome, home overnight non-invasive ventilation is likely to be the correct management. Promote a limited diuresis with judicious use of diuretics. Always elevate leg when sitting. Some will venesect if hematocrit exceeds zero point 0.6, but no randomized controlled trials evidence of physiological benefit or a reduction in hyperviscosity complications. Treating the blood gas disturbance and improving burdensome peripheral edema are the main therapeutic aims. The long-term auto trials showed that improving the PaO2 was useful, not that lowering the PAP was important. Specific agents used to lower pulmonary artery pressures used in PH have not seen shown to help in core pulmonale. That's all about core pulmonale. Thank you.